This case is an example of a neurologic deficit after lung cancer treatment. A patient with a previously treated pancoast tumor now presents with weakness and muscle wasting on the medial side of the hand, affecting grip strength. So the patient has a previous history of pancoast tumor and now presents with weakness and muscle wasting on the medial aspect of the hand, affecting grip strength. What is the most likely cause? Radial nerve injury, chemotherapy-induced neuropathy, ulnar nerve entrapment, cervical myelopathy, compression of the lower brachial plexus. The correct answer is compression of the lower brachial plexus. Explanation: the pancoast tumor usually arises at the lung apex and commonly invade the lower trunk of the brachial plexus, which is made by C8 and T1 nerve roots, leading to hand muscle wasting and weakness, particularly affecting the intrinsic hand muscles. So first let's talk about the brachial plexus. As you know, the brachial plexus has three trunks: superior, middle, and inferior trunk. The inferior trunk is made by C8 and L1 nerve roots. The superior trunk is made by C5 and C6 nerve roots. The middle trunk is made by C7 nerve root. The inferior trunk is made by C8 and L1 nerve root. C8 and T1 nerve root. A pancoast tumor, this is the first step. So when a pancoast tumor arises here in the lung apex, it usually invade the first strip and also invade the lower trunk or inferior trunk of the brachial plexus, which is made by C8 and T1. C8 and T1 nerve roots, if you look here carefully, C8 and T1 nerve roots, the median nerve is made by them. C8 and T1, the radial nerve is made by them. Okay. Also here, the ulnar nerve is also made by C8 and T1. So compression of the inferior trunk of the brachial plexus will lead to weakness and wasting of the hand muscles. This is an example of pancoast tumor case. A middle-aged man presents with a new and persistent cough. The erect radiograph of the chest showing an area of increased density at the right lung apex. There is an area of increased density at the right lung apex. This has an irregular lateral border. An area of increased density at the right lung apex. This has an irregular lateral border. No differential densities are seen. No other focal lung opacities. So this is a pancoast tumor. CT scan of the same patient, axial CT images, lung windows show a speculated mass at the right lung apex that abuts the pleura posteromedially. This is the CT scan of the chest lung window showing a speculated mass at the right lung apex. Speculated mass at the right lung apex, which abuts the pleura, abutting the pleura posteromedially, the posteromedial aspect of the pleura. There are no obvious signs of chest wall or rib invasion. But there are focal lucencies in the mass, which is likely to be caused by the background emphysema rather than cavitation. So these lesions showing multiple focal lucencies may be caused by the background emphysema. Okay, so in this case, you can see that the pancoast tumor can invade the apex of the lung and invade the pleura, and also can invade the first rib, and here can invade also the nerve roots, the cervical nerve roots, the lower cervical nerve roots and the upper thoracic nerve roots of the brachial plexus. So invasion of the nerve roots of the brachial plexus will lead to maybe invasion or compression, okay? May lead to weakness of the hand muscles. Another case of lung apex mass on the chest X-ray. This patient has shoulder pain. He's a 40-year-old female with shoulder pain, and this is very important. She does not smoke. This is the chest X-ray. Can you see this opacity here? Okay. There is a well-defined spherical opacity projected over the medial right clavicle and the lung apex. There is a well-defined spherical opacity projected over the medial aspect of the right clavicle and the right lung apex. No bony or joint abnormality. Further investigations with MRI is advised, including the cervical spine, to determine the cause of the shoulder pain. What is the most likely diagnosis in a non-smoker? Schwannoma or neurofibroma. What about the most likely diagnosis of this lung mass if the patient is a smoker? Pancoast tumor. Okay, so how to distinguish between pancoast tumor and schwannoma or neurofibroma? By MRI scan. MRI scan and also by history. If the patient is a smoker, the most likely diagnosis here is pancoast tumor. If the patient is non-smoker, the most likely cause of the shoulder pain is schwannoma or neurofibroma. So MRI scan, including the cervical spine, will confirm the diagnosis. This is the MRI scan. This is the lung. Can you see these lesions? So the lesion is arising from outside the lung. So it is not pancoast tumor. It's not of pulmonary origin. However, these lesions is most likely to arise from the lower cervical nerve roots and the upper thoracic nerve roots. This lesion is most likely to be neurofibroma arising from the brachial plexus nerve roots. As you know, neurofibroma on T2 weighted image will be of high signal with central areas of low signal. The diagnosis was neurofibromatosis. Okay, these lesions are neurofibromas. Neurofibromas and schwannomas. What is the main difference between? Neurofibromas affect 20 to 30 age and is usually solitary. Neurofibroma usually tend to be solitary. However, schwannomas tend to be multiple. Sorry, the opposite is true. Schwannomas most likely to be solitary lesion. However, neurofibromas most likely to be multiple lesions in neurofibromatosis with an association with neurofibromatosis type 1. Okay, so as you can see here, these lesions is not solitary. Okay, so this is most likely to be neurofibromatosis. Okay, this is the target sign of neurofibromatosis. High signal, peripheral high signal on T2 weighted image with central area of low signal. Sorry. Another case here, seen here. This is the MRI scan of a patient with brachial plexus neurofibroma. Brachial plexus neurofibroma. There is a well circumscribed rounded mass along the right brachial plexus arising from the lower cervical nerve roots of the brachial plexus and the upper thoracic. The mass is of heterogeneous signal on T2 weighted image, and in post-contrast T1 weighted image, it enhances. The mass enhances on the post-contrast T1. The mass extends back along the right C7 and C8 nerve roots with expansion of the neural foramina. There is expansion of the neural foramina. The mass here is heterogeneously enhancing with contrast, and this is the expansion of the neural foramen. Okay. So the brachial plexus consists of C5 and T1 nerve roots. Consists of the C5 to T1 nerve roots. So the brachial plexus consists of C5 to T1 nerve roots. As I mentioned, C5 and C6 will form the superior trunk. C7 will form the middle trunk. C8 and T1 will form the inferior trunk of the brachial plexus. The brachial plexus will course inferolaterally towards the axilla to innervate the arm. It runs between the scalene muscles in close proximity to the subclavian artery. Patient commonly present with shoulder pain, arm weakness, shoulder pain and arm weakness in case of compression of the brachial plexus nerve roots. There is arm weakness. So here the pancoast tumors, when arise at the lung apex, commonly it invades the lower trunk of the brachial plexus, which is formed by C8 and T1 nerve roots, leading to hand muscle wasting and weakness, while the other options are incorrect. Radial nerve injury affects the wrist extension. Chemotherapy neuropathy is usually bilateral and sensory. So chemotherapy is sensory. Ulnar entrapment is unrelated to lung tumors. Cervical myelopathy. Cervical myelopathy causes upper motor neuron signs. In the case of cervical myelopathy, there will be upper motor neuron signs.